Hi, thank you for joining me today. Today we're going to be speaking about cerebrovascular accidents. Cerebrovascular accident or stroke is an incident that happens in the brain. These things are caused by possibly one of two very traumatic, very dangerous events. Either as an ischemic stroke, in which case there's a blood clot in one of the arteries in the brain, or more than one artery in the brain, or a hemorrhagic stroke, which is caused by an aneurysm which bursts inside the brain, one, two, maybe three, who knows how many. Both types are very, very dangerous, extremely life-threatening, and it's important for us to get an accurate diagnosis and an early treatment in order to prevent death and to ensure the successful rehabilitation of the person. Now, when we learn about these things, they teach us things like FAST and be fast to spot a stroke. Be fast, let's just explain quickly. Balance. Is the patient or yourself having difficulty balancing? Are they feeling lopsided when they walk? Do they have this dizziness when they want to move around and things like that? Eyes, are they having blurred vision, or is maybe their pupil response a bit different to what it should be? F stands for face. We look at facial symmetry. Is there a droop in the one side of the face? If the patient smiles, is the one side saggy and the other side normal? When we look at arms, we ask the patient to close their eyes first, raise their arms slowly and try and hold them there. We ask them to close their eyes so that when they're busy doing this, they don't see if the one arm is weaker and maybe it droops slightly, or they try and counteract that by trying to put a bit more extra effort into picking that arm up again. When we look at S, we look at speech. Have the speech patterns of the patient changed? Ask their people that are close to them, have they had problems pronouncing T and H or SH or which, this? Those type of things where the tongue is involved in making sounds against the roof of the mouth or the teeth. We always check for things like this. Okay. And finally, we time with T for time, test all three. This is a time critical incident. We need to get these patients to hospital as soon as possible in order for them to get checked out properly, and treatment must be administered as quick as possible. We spoke earlier about the ischemic stroke or the hemorrhagic stroke. When we look at treatment for these things in a very diluted way, you would not treat a hemorrhagic stroke with a blood thinner as you would treat a thrombosis with a blood thinner to try and break down the blood clot and allow the blood flow and oxygen to return to that side of the brain. So it is of critical importance that we actually diagnose this quickly, correctly, and as fast as possible. Some of the signs and symptoms they tell you about that you should be looking for: obviously a headache, throbbing headache, temple area, maybe blurred vision. You must remember sometimes with these things, there will be nausea and vomiting, projectile vomiting, especially if there's some sort of a brain injury. The loss of feeling in the extremities, your fingers and your toes, getting a bit of pins and needles going there. Maybe even a bit of ringing in the ears, not related to tinnitus or anything like that. Unconsciousness is a definite possibility with a stroke patient. When the stroke patient is having their episode, there might be twitching in the muscles or stiffening up in the muscles. There's something definitely we can look at while trying to gain levels of consciousness and speaking to your patient, trying to rouse them. There may be incoherent noise or sounds. They might think they're talking to you, but they're babbling. They're just not making sense, you know. When we check the pulse points, the radial pulse in the wrist or the carotid pulse up in the neck, we're finding that the pulse is bounding. It's beating on the inside like a frog jumping up and down, trying to get out. There's possibly a loss of bladder control or bowel control. If we look at this thing in a strictly medical point of view or from an ambulance point of view, it may be a bit messy. The pupils, we will always check to see if they equal and react to light equally. Unequal pupil control would definitely indicate some sort of brain injury, some sort of event that's taken place. And once again, we just check on the normal sample history of the patient, signs and symptoms, allergies, medication, previous illnesses, hypertension. Definite worrying factor, hey? Last meal and obviously events leading up to this type of incident that's going on. Yeah, we need to know why, how, and when these things happened. Now, what they don't teach you, and this is very critical, is that every patient is unique. No one person is exactly the same. Sometimes the acronym FAST, only presents way after the fact. Sometimes these things are so slight we don't even pick them up. Okay, the untrained eye, we don't even notice it. We don't know the patient as well as the people that live with the patient or that know the patient well. So we might have to ask them, are there any things that are different? Like I said just now, the signs and symptoms may be so slight that we won't even know how to do it. If we do a proper primary survey or primary assessment, we check the pulse, we check everything else, we check the patient out very well. You've got to remember that these things are critical, absolutely critical. Signs and symptoms, allergies, medication, deformities. We look for things like this while we're doing our survey, sample and dots. Now, when we look at a stroke or a cerebrovascular accident or event, there's different types of things we can look for. Sometimes we have what we call a transient ischemic attack. Now, transient would be something that would be moving through. Ischemia would be death. So we're looking at things like a blocked artery with a blood clot, which presents itself and looks like a stroke, but the next day they're fine again. Okay, what all it is happening is there is a small blood clot developing in the brain or something like that, and the body has its ability to dissolve these blood clots, to break them down, so things look like they're returning to normal. However, and this is a big however, if you're having a TIA or transient ischemic attack, I can almost guarantee that you're going to have some sort of episode very soon, and it's not going to go away. In fact, it'll probably put you in hospital or in the ground. Those type of things are sudden and severe. Things like Bell's palsy is usually defined by a stressful event in your life, writing exams or going through some sort of trauma or something in your life. And when things have to change, your body can't always cope with these things, especially major things, death, divorce, moving, things like that, exams, all those kind of things kind of tend to present under stressful situations in Bell's palsy. Now, what do we do now? We've diagnosed this patient. We are convinced this patient is having a cerebrovascular accident. Well, if you've done your primary survey, hopefully by now you've got help fast. This is a life-threatening condition. We need to act quickly. We need to ensure the ABCs, airway, breathing, circulation, are functioning correctly. If there's any doubt in the patient's ability to maintain an airway, are they breathing enough? Is there circulation? We need to be prepared to do CPR. Shock is what's going to kill your patient. At the end of the day, we need to get it sorted out. Try and pinpoint the nature or the cause of this cerebrovascular accident by finding out more about the patient. Has he had high blood pressure? Has he had an immense amount of stress? Has he had blood clots before? Does he suffer from blood clots? Is it something that has been a regular thing since COVID? We don't know. We need to ask the people around them. And remember, if you haven't received or gotten help yet, do it quickly. Time is running out for this patient. We need to act, and we need to act now. We then need to decide whether we're going to place the patient in the recovery position with postural drainage, especially if we're worried about this patient losing consciousness. We don't want them lying on their back and maybe choking, especially on a bit of dribble, spit, saliva, anything that's coming out of this patient's mouth. There's a good chance of that. There's definitely definitely a chance of choking if the patient is left lying on their back. We need to monitor the patient closely. This I would classify as a critical patient. We need to be monitoring vital signs constantly, talking to them, making small talk, trying to establish how things are going. The best way to find out if a patient's condition is worsening is if they stop talking to you or they start talking garbage. We need to try and keep the patient awake. We need to try and communicate constantly with the patient. If, however, the patient is unconscious, we need to try and wake them. We need to try and establish some sort of level of consciousness. We need to constantly monitor this patient and get this patient some help. Treating this emergency, well, definitely make sure by now that your help is around the corner. By this time, as we're speaking, help should be on its way. Do not panic. The worst thing you can do as a responder or as a first aid or anything like that in a situation like this is panicking. We need to perform our primary and secondary assessment as soon as possible, effectively as possible. We need to get treatment going as soon as possible, okay? If the patient is conscious and we need to try and calm them down, we always can try the 4-4-6 method of breathing. 4 in through the nose, 4 seconds in through the nose, hold for 4, and blow slowly out through the mouth up to 6 seconds long. The longer we can blow it, the better it is. It seems to calm the patient. It seems to also flood the patient's body with a bit of nitrous oxide, which in turn will dilate the arteries. And if there's a blockage, hopefully that type of thing can happen and we can have a little bit of blood flowing through to these things. Always be careful if you're suspecting an aneurysm. We don't want to try and force anything else out through that thing. The higher the blood pressure, the better, the more chance they have of bleeding in the brain. We're trying to reduce the blood pressure in the brain by doing this nitrous oxide breathing, 4-4-6. We as first aiders, rescuers, anything like that, we have nothing to provide a vasoconstriction or vasodilator to the patients. If we calm and reassure the patient by breathing deeply, slow breaths, like they're blowing up a balloon, it's just going to help the patient in the long run. The biggest trick here is get the patient to hospital as soon as possible. Man, time cannot be wasted on nonsense with these people. Unless you're a trained paramedic or an emergency room doctor, you don't have the tools to even think about trying to help this patient. What I can say to you is thank you at this point for listening to me. If there's anything else you'd like to hear about or to discuss or anything like that, please leave a comment in the comment section. And don't forget, please, to like, share, and subscribe. Let's get this out to as many people as possible. It's been more and more places that I've been listening to and hearing to about people having strokes and episodes of the brain. It's becoming very concerning. We need to do something about it. Thank you for listening and goodbye.